Good afternoon, everyone, and thank you for being here. I'm Felipe Filomeno, Acting Director of the Center for Social Science Scholarship, which coordinates the Social Sciences Forum Lecture Series. This is our fourth Social Sciences Forum lecture of the semester. It is hosted by the Erickson School of Aging, so I would like to thank the school for organizing this event and also our co-sponsors, the Hilltop Institute, the Delta Lambda chapter of Sigma Phi Omega, the Department of Sociology, Anthropology, and Public Health, the Office of Equity and Inclusion, the UMBC doctoral program in gerontology, and the Center for Research on Aging. Before we begin, I want to mention our final lecture of the semester, which will happen on May 3rd, that's a Tuesday, at 4 p.m. The Department of Sociology, Anthropology, and Public Health will host the Health and Inequality Lecture with Dr. Dana Ain Davis. She is a professor of urban studies and anthropology and director at the Center for the Study of Women and Society at the Graduate Center of the City University of New York. She will present Grammars of Racism, Obstetrics, and Black Antibodies. This will be a virtual talk. You can find more information on our website, socialscience.umbc.edu. I would also like to invite you to engage with us on social media. We are on Facebook, on Twitter, on Instagram. Just look for @UMBC SocSci. We recently launched a podcast called Retrieving the Social Sciences, which you can find on Spotify, Apple, or Amazon. Several of our previous talks are there, so I hope you will be encouraged to subscribe to that. A few housekeeping details. The audience today will be muted with video off, but we very much welcome your comments and questions. Just make sure you put those in the chat box at any point during the talk, and we'll do our best to get to them during the Q&A. Thank you again for being here, and I will now turn things over to Dana Bradley. Dr. Bradley is the Dean of the Erickson School of Aging Studies, who will introduce to you our speaker. Thank you.
So happy Tuesday. Welcome, everyone, and welcome to Careers in Aging Week as well, an international event that really celebrates all the pathways that universities have. And we're very fortunate here at UMBC to have a number of pathways that really provide that exciting place for our students where they are to be where they want to go. And part of that is understanding research that underpins so much of best practice. And I am so pleased today to welcome Dr. Ishan Williams to our gathering. And if we were in person, I mean, I have to share. So 2 weeks ago, we were at the Southern Gerontological Society meetings, and I got to see her for the first time in, oh gosh, it's been over 2 years in person. And so I'm so excited that you all are going to get to benefit from her wisdom and advice as we think about this really important topic about dementias and Alzheimer's diseases and how we understand better the science and the practical application of how we can develop new alternatives, particularly for communities that we have not looked at, that we want to connect with more. So who is Dr. Williams? Well, she studies the quality of life and health care among older adults and their family caregivers with a particular eye, with that laser focus on vulnerable populations. Her current research focuses on quality of life issues among older adults with dementia, chronic disease management, and those with type 2 diabetes, with a particular focus and a link among cognition and vascular problems with older African Americans. Dr. Williams earned her degree in psychology at UNC Chapel Hill, an MS and PhD in human development and family studies at UNC Greensboro before completing a postdoctoral fellowship at UNC Chapel Hill's Institute on Aging. She's a member of the National Hartford Centers for Gerontological Excellence, a fellow of the Gerontological Society of America, a Victor Marshall Fellow, and a past president of the Southern Gerontological Society. I note that Dr. Williams serves in a number of leadership capacities across professional associations I'm going to say in the U.S., but really internationally. It is my pleasure to welcome her to our event today. Dr. Williams, I should say the floor is yours, but I guess I have to rephrase that. The screen is yours.
Well, thank you, Dr. Bradley. It is so nice to be with you all. And let me just start out by saying thank you for the invitation to come and speak today. And I hope we can have a conversation and a discussion about these issues. And I'm going to share my screen. That's right. Okay. Are you all seeing the right thing? Yes. All right. So first, let me again thank you for the opportunity to share a little bit about my research program, and hopefully in the midst of that, you will hear the passion of why I do the work that I do. So excited to have this conversation and see where what other ideas come out during our question and answer. So the title of my talk is Understanding the Vital Importance of Engaging Diverse Older Adults with Dementia and Their Communities in Research. I wanted to start out because, as Dr. Bradley said, we are in the Careers in Aging Week. And so for me, I just felt like I needed to have a slide that talked about where my aging career started. And when I started to think about, you've heard with Dr. Bradley's introduction of me, sort of where I did my education, and I sort of have that on the screen. But the middle is really how I feel like my career has gone in aging. It started with me in psychology, and I should say that I was born and raised in North Carolina, and the youngest of two sisters. I've always been a Southerner, so I think that context matters. I also, when I started in psychology, I'm a Tar Heel, although I work for the University of Virginia. I am a North Carolina Tar Heel. That's where I did my undergraduate degree. Went in psychology, and if anybody's on the webinar that has a psych background, you'll know that you knew you were going to go do something else. You knew you couldn't stop with an undergraduate in psychology. And so I really had no idea what I wanted to do besides like work in social work. But that didn't seem to mesh with my ideas in terms of what I thought my psych degree had prepared me to do. And so I took what students are calling now, it didn't have this nice word then, but they call it a gap year. So I took a gap year and I went home to North Carolina. I worked at Wake Forest Medical School in Winston-Salem, North Carolina, which is home for me. And how I got that position is because I was an undergraduate researcher during my psychology program. And because of that experience with data collection, doing interviews, and the research skills that I had developed in undergrad, I was really able to figure out how to train someone else in the research program. The research program that I connected to was geriatrics. They needed someone in the field of geriatric medicine, and they were looking at an intervention with older adults living in a community who came to the hospital. So these were older adults and their family members, but in an interdisciplinary clinic. And it was really focused on caregiving. At that point in my life, I had no idea that I would want to do something in aging at all. But I became pretty immersed as a data collector of going into the communities and really seeing where the significant gaps were in terms of what the needs were, how different families on different parts of the town, how even they lived and experienced aging and caregiving, what resources they had access to. And so I would take this back to our interdisciplinary team that included a pharmacist, a physician, a social worker, a PA, a nurse practitioner. We really had an interdisciplinary group. And that's when I started to get this itching for, oh, wow, I might need an actual PhD to do and to ask some of the questions that I had in order to really investigate those questions. And so during that time frame, my grandmother at the time needed some more physical help, like with her functional abilities. And I came to live with my grandmother. And in that span of time, my mother became a primary caregiver. And I should say that my grandmother did not suffer from Alzheimer's disease. But again, because of my immersiveness in the community, I started to really see that Alzheimer's disease and dementia was hugely impacting our community. And I wanted to know more about what we could do to support families living with that disease. So I went to grad school and then later took a postdoctoral fellowship. And then my first job out of my postdoctoral fellowship, well, my postdoc was in healthcare and aging. So I still kept that sort of interdisciplinary focus because I really wanted to, you know, as someone with a human development degree, I really wanted to make that I worked with a team of diverse backgrounds because that seemed to be, to me, suitable to really look at life course events across the lifespan in order to understand how these experiences impacted families. And so I had my first job opportunity in the School of Nursing. Now, that may seem really odd. Like, how did I get into the School of Nursing? Well, they were really looking for scientists who really were interested in aging. And although not a nurse, I had worked with nurses. So I didn't feel sort of out of my realm. I didn't feel out of order. But it was different from nursing colleagues, I think, to work with someone who was not a nurse. So that's been definitely an interesting journey. So I'd be happy if people have questions about how some of these decisions were made and how I got to the point where I am today. And as Dr. Bradley mentioned in my introduction, I've also dabbled a little bit in some leadership opportunities too in aging and in diversity that I will bring up later in this talk, and hopefully we'll have time to share more about that. But as you can see, this middle section of my slide, it wasn't a straight pathway. I love to see these timelines where people often think that their careers will go step 1, step 2, step 3, but that is often, as I tell my children, not the way life happens. So be open to opportunities and to take some risk, I think. I'm going the wrong way, so let's go back. Here we go. So now going into the talk, I really want to, these are just the objectives that I have for today. It's just to provide an overview of Alzheimer's disease, some of the risks associated with it. I will also discuss the disproportionate effect on African American and Black communities, which is my primary area. Talk about the impact of underrepresentation in Alzheimer's disease research and why I'm so passionate about continuing to change that narrative. And then finally, I will end with describing innovative approaches to provide outreach opportunities to recruit more representative samples. So really talking about best practices that I have used in my own research to use community engaged approaches. So just a little background and significance around Alzheimer's disease. So Alzheimer's disease is a neurodegenerative disorder where symptoms usually start slowly and they gradually worsen over time. Of 7% of clinical cases of dementia, and it affects approximately 6% of people 65 years and over, and approximately 50% of people who are at least 85. Now, in many developed countries, including the United States, Alzheimer's disease is the most financially costly, exceeding the annual cost to society of even cancer and heart disease. So presently, there are approximately about 50 million people worldwide suffering with AD. And the symptoms most begin in people over the age of 65, although about 5% of cases are considered early onset Alzheimer's disease. And as I started in talking about Alzheimer's disease, it's important to know that Alzheimer's disease is the most type of dementia, and persons are unable to store new memories. They may not be able to recall what they said. So this might be someone who continues to ask questions after question after question, the same question over and over. And often, sometimes most diagnoses are only able to be, you're only able to get a diagnosis if you have like a spinal tap or a PET scan or other research type of clinical studies that include blood tests before you can actually get a diagnosis. And so you'll hear people talk about what's the difference between normal aging and cognitive decline. And in normal aging, the body and the brain quickly slow down as we age, but your intelligence will remain stable. Now, persons who have mild cognitive impairment, they have notable problems with memory or other brain, other core brain monitoring their health and treat any problems that arise. So and then dementia really starts to impact how your everyday living, like how you live every day. And talk about who are, if they are at risk. And here's a slide that I've borrowed from my colleagues at the Alzheimer's Association, where you can see the risk factors. And these are known risk factors for Alzheimer's disease. Clearly age, family history, heredity, head injury, and lifestyle behaviors. It's really important that you notice here is that 1 in 3 seniors are known to, or will be known to die with Alzheimer's disease or another dementia. And as I mentioned earlier, it kills more than breast and cancer combined, breast cancer and prostate cancer cases combined. And I'd like to also point out is the connection between our heart and our head is that some of the strongest evidence that we have really links brain health to heart health. And this connection really should make sense because the brain is nourished by one of the biggest, the body's richest networks of blood vessels, and the heart is responsible for pumping blood through the blood vessels to the brain. And so we really do, should pay attention to these risk factors. But what's even more important is that when we look at these risk factors, we start to identify who's disproportionately affected. And we see here on this slide that Blacks, African Americans, Hispanics, and women are at higher risk for developing Alzheimer's disease than whites. And Blacks are 2 times more likely, and Hispanics are about 1.5 times more likely than whites to have Alzheimer's disease or other dementias. And what's a really key point that I have here on the slide is that even though the prevalence rates are higher for some of these under-resourced and minority populations, they are less likely to receive a diagnosis. And there are a variety of reasons for why they are not receiving these diagnoses. And so we'll talk a little bit about that. So again, going back to risk factors, what I wanted to highlight here is that these are often risk factors that are disproportionately presented in populations that have been marginalized in our community, and also then has an interactive effect to have more prominent impact because these are conditions that are either related to poor housing, poverty, inequalities, or other structural barriers that could potentially influence the way we experience risk for cognitive loss. So as you look at this list, you may see many of the modifiable factors, things that we should be able to potentially influence by changing certain behaviors. And by doing that, I think we're, as researchers and scientists, we're really in a good position to be able to talk about how do we reduce some of these modifiable factors, because as we know, there aren't real cures to Alzheimer's disease, that we really should focus on non-pharmacological interventions to promote within communities that will help serve them the best. Also in my work, one thing I would like to highlight is that I'm currently working with a group of scientists at the University of Virginia, really trying to develop a center on transformative innovations in basic clinical and translational research that involves neurological, social, behavioral, and economic aspects of aging, as well as dementia and as well as caregiving, because we think that including these interdisciplinary areas of research that we can really impact the health of diverse patients, who their caregivers and their communities who are living with disease. And one of my primary areas of research is really focusing on caregivers, because this slide, as you see, is that $271 billion of care is provided by family members. And often dementia caregivers experience significantly higher rates of dementia relative to their age-matched non-caregivers. So this is something really important to point out, because we really don't have enough research to really show us what factors are really involved from, or that are influencing, coming from caregiving to a person with dementia, and how that influences the onset of dementia for the respective caregiver. So these are things that we've been trying to do more research in this area, and focusing again on the dyad, not just interested in the patient with dementia, but really looking at the dyad and how important it is for us to understand the impact of caregiving. And also the diverse needs within and across these families. I talked a little bit about intersectionality. You know, we have, if you're an African American and you're a female, you're going to have double the risk of getting Alzheimer's disease, and the prevalence rates already within African American community higher. So we have to understand and have to address these communities that have often not been included in clinical trials, have not been included in research for various reasons, but often because of that, a lot of what we know, we have to continue to explore and be more inclusive. So that's one of the things that we're trying to better understand. Now, when we talk about health disparities and culture, I think, you know, when we think about health disparities, I often feel like they are often intertwined with social justice issues that are often a barrier to support the equal treatment for minoritized populations and those from underserved communities, those who have limited access and economic resources. So I think in understanding differences, different identity groups, as well as geographical region, that's another focus area of mine. Those who live in rural populations and remote areas who have they're under-resourced in their areas because they don't have access to specialty clinics or enough doctors to do the referral process that's needed to actually get a diagnosis, then limiting the access to treatment and, of course, diagnoses. And so more education, I think, is needed on how we understand how the culture of a person's background really can influence the way that they understand the disease and the way they interpret the disease, as well as how they proceed in care in living with the disease. And so I think the overall goal is to provide environments where people really do feel that they receive effective, equitable, understandable, and respectful quality of care and services that are really responsive to the needs that they have within their community and within their own health beliefs and practices. So from understanding health disparities and how culture has really been an influence in the work that I do, I've really focused on how do we now spend more time on centering equity? How do we get to the place where we not only see the words, because I think in the last couple of years, we've all heard these words multiple times, but I'm a person who believes in not words, but words and action. And so for me, I explain diversity, equity, inclusion in this way. Often I see diversity as you make sure that you have a seat at the table. You're just going to make sure you have a seat at the table. Equity, though, ensures that the seat that you're actually in is your best seat and it fits you. And then inclusion really refers to making sure that not only is your seat the best seat and the best for you, but now you're actually able to have your voice heard at the table discussion. So you're invited into that conversation, not just sitting at the table, but you're actually involved in joining the conversation. So what does that look like in practice? How do we see ways of incorporating diversity, equity, inclusion in research and centering that work, even throughout the research project that you develop? So in practice, we can seek out ways to engage in, again, culturally sensitive and humble care for our increasingly diverse populations, and think broadly about diversity and identity, and how those can have an influence on how we engage with populations. Identifying assets and our strengths of the population. These can be leveraged. I think for so many years, we often had a deficit, and I say the universal we as researchers have had a deficit in how we understand why people have lived experience that they do, or why they have a particular medical condition, or in a healthcare, in promoting healthy behaviors, that we often blame individuals, we often blame communities for those situations without really identifying their strengths and their assets and how they can actually be leveraged. And lastly, I think one of the most important things on this slide is to build relationships with the communities that you're interested in working with, and in helping to minimize the impact of negative health outcomes. And we build these relationships in order to develop trust. And I just can't say that enough. I think that's been one of the key concepts that maybe I didn't learn in graduate school, but my community taught me really quickly in rolling out some research in the community. So building relationships really does build trust, and we definitely need more of that in order to, oops, going the wrong way again. Sorry, in order to move research in a more inclusive way. So I wanted to incorporate this this quote because it just meant so much to me to see this. This was recently spoken by Paula Lance at a recent Health Equity Summit. And she says, there can be no progress toward health equity without naming, framing, and dismantling of structural racism. And I think that when we think about how disparities are not minimizing, we haven't reduced disparities over time, we really have to change the way that we have been doing things in order to start seeing some true reductions and improvement in health over across all of our groups and within groups. But when we think about structural racism, we have to then understand that there are structural barriers related to discrimination, to lack of trust within healthcare systems. History actually does matter. And so it's important to understand how these structural systems were put in place in order to start dismantling them. So if you don't think that they're actually there, and you have no awareness that they exist, then you're not really addressing some of the key areas that potentially could be the impetus for really moving and changing our plight forward in these areas, especially in areas where we've seen huge disparities. Because I'm trying to remember the name of the report, but it suggested that of all the disparity groups where African Americans and Blacks have been less favored in those potential disparity groups, that they are still 5 times more likely to die they're more likely to die 5 years earlier than white populations in all of the disparity categories across the board. And that's in 2021. It's like, this is where we are. And I think that's a rude awakening for some of the things that we really need to be doing. So I love this centering equity picture from the Robert Wood Johnson Foundation at the bottom. Many of you may have seen this, but I really, again, want to emphasize, if you look at the picture, you can see the top part focusing on equality, but the bottom part focusing on equity. And you see the differences in how equity really pushes us forward to more inclusion, and not just that everyone has a bike, right? We really do have to look at how equity differs from equality, in seeing how it embraces the notion that we may have to have different situations or different measures across population in order to center equity in our work. So, and again, what this might help us to do is to really understand how we can map these things in healthcare, and asking the right types of questions, and how we see that, again, not necessarily focusing on equality, but on equity. So moving to talking about representation in research, I think it's really important to understand how the care needs and the supports that are often with diverse groups, if it's not considered in the beginning of the oracle trial, often it's not going to be inclusive of the populations who are most at risk or those who are disproportionately affected. So how this is represented in a lot of work that I do is that I look at the ways in which I recruit for my studies. Am I only going through the clinics, through a primary care practice or a neurology clinic to get, or how does the community find out about these research studies? Like what is the level of knowledge of what research really, how can we target, and I don't like the word target anymore, but how can we focus our attention really on communities to help them better understand the utility of research and why they could be benefited or not, but why it's important to participate in clinical trials and other social and behavioral research studies. As we know historically, a lot of our assessment tools, even in the field of cognitive aging, has not been inclusive of people of color. And so often what that means is that we have very few tools that are able to be applicable to a large population, and especially to those groups who are disproportionately affected. And so when we really start to center equity, we start to think about what even our inclusion and exclusion criteria are. I've had several studies where we've had to adapt or revise our inclusion criteria because for the populations we really wanted, they were never going to get in with those inclusion criteria. Either one time I was doing an intervention with type 2 diabetes, and we had the BMI set so low. I was like, well, African American average level of BMI 1. Why are we still using BMI? But that's a whole nother talk. But using BMI, we had to change that factor, that inclusion criteria, because we were excluding the one population that we thought could benefit from the intervention. And so being able to be flexible and changing your paradigm as you think about how to center equity and how to include people, we really then start to say that this is not the way we used to do things. This is not the traditional way that research has always been done. And in doing so, you begin to include folks and include people value that, well, they see the value that you have for their contribution in your research. And I think that's where we definitely need to get to. And then you start to have voices that have often not been heard to be part of the conversation and not excluded. So some of the recruitment goals that I've identified in my own work is to really, it's really a systematic approach to minimize any types of marginalization that I have felt like, or that, there's lots of evidence out there on best practices in recruitment and enrollment of populations, but really starting to think about, whose voice is hidden. How do we engage with populations who may historically not have a good relationship with the institution that's doing the research? So I'll talk about University of Virginia because I work there. And so the University of Virginia does not have a good history in providing care to some of our underrepresented populations in the area. And often when we're talking about research in the community, that is the one thing that people bring up. They're like, well, do I have to come to UVA? Like, they don't want us over there. I mean, you'd be amazed at how open people are about why they don't want to participate in research. But sometimes I hear more that there are participants who are saying that they just never were asked. They just did not have the opportunity. And is that because we're not going to tower, or is that because of trust? Is that because of the relationships that we need to build? Because obviously what we've been trying to push at the University of Virginia is that there is a lot of room for repair, right? There's a lot of room for repair in research, in clinical research, and even in education and partnerships that we have with our community. And so again, challenging traditional ways of knowing. But I also think one thing that I've been told with my participants is that often when they hear you talk about disparity, because of how disparity literature is and what people hear on TV and the stigmatization around, again, blaming individual populations or communities for their plight, that turns them off. They're like, that's not me because I'm not in that group. Whereas when we talk about prevalence rates and how much more we see this in prevalence, that seems to really resonate with communities of color and those that are usually have remote access or under-resourced, because then they start to see that, wait, that's a structural issue, right? Like there are things that are out of my control, but that were set up before I even entered this life course, right? Before I entered this space of living with this particular disease. And so talking about it and we work together to, again, identify ways that we can move forward in reducing these gaps in care. And I included this resource at the bottom. This is a really nice community advisory board toolkit, and it has some really good links that you can go to for other resources on how to be more inclusive and to focus on equity in integrating community voices. So I wanted to put that link here, and I do believe the slides will be available. So what can we do about it? Again, community engaged approaches, I believe, promotes healthy living. It reduces these health gaps that we see across disease, especially in Alzheimer's disease. And it also strengthens the capacity for communities to create their own healthy paths. Whenever you can co-create the interventions with communities who will then engage in those interventions or those lifestyle and health promoting behaviors, you're likely to have better outcomes and better retention with those programs as well. And so I want to just shift really quickly, and I can't see the chat, so I know that I'm close on time, but I just wanted to talk really briefly about 3 of the research projects that I'm working on right now to give you a sense of how we've engaged our community, and I found it to be really probably more rewarding for me, but definitely a rewarding experience. So starting out, I talked about the Animating Alzheimer's disease. This is one of my newest projects that I'm working with one of my colleagues, Dr. Jack Van Horn, and Dr. George Bloom, who's a biologist, and Jack is a data scientist. And what we're doing is we're creating a little film. And in this film, it's going to incorporate not only the biology of aging and what happens in the brain when Alzheimer's disease, the process of, the tau and the tau pathology, and how that occurs over time. But also, as you see these other pictures on the slide, is that we're also incorporating the voice of the caregiver and the patient. Like, we want to make sure that what we are seeing in this film, what is actually happening in the lifestyle of a caregiver? What is actually happening with the patient during this time of, the process of what's going on in the brain? And so this is Wendy Cooper and her mom, and she's a part of, and I'll talk about next, one of my community advisors. But this is going to be really exciting because it's almost like a Pixar film, but it will be a way to be amazed at how little people understand about the biology of the brain. And we were really trying to get a way to make something that can be put into the community so that people can understand it. And so combining those 2 avenues, I think, is going to be exciting. The other thing is I've worked with our CTSA, which is a federally funded program through NIH, and worked with developing community engagement studios for our research projects through the University of Virginia's neurology department. And so what a community engagement studio is, and this was developed by Vanderbilt University, is that they give community members an effective and active healthcare. So I, as a researcher, am not involved in recruiting people for this studio. All of the people come through the iThrive staff, and that's who our CTSA is. And then the other goal of the CTSA, of the Community Engagement Studio, is to encourage researchers to consult with patients and the public before, during, and after each research project takes place. So this is a project that my colleagues and I are working on. It's an intervention for caregivers called Effective Strategies Program for Caregivers. And it revolves around 8 topical areas. And so we went and partnered with iThrive to really ask us identify what we needed to do within this program that would be acceptable to the community. Now, this was into all family caregivers, and so she just put our iThrive partner, Kristen, put out a call in the community to have a focus group. And so we were given very strict orders about, you know, we can have, as researchers, we often over-explain. And so we only expected to give 7 slides and had to do a very good job of being succinct about what we were asking community. And so this slide here shows some questions that after we gave a brief overview of what types of, what we thought the intervention, how we thought the intervention could be implemented, we asked them questions about would they come, you know, do you feel safe with COVID? Like, how would you change it? What other topics are you interested in that we may not be interested in, or that not that we weren't interested in it, or that we have not included in the intervention? And so this just idea again of some of the things that, and we got such great feedback from the group that what we will do now, we went back to changes based on the feedback from this community engagement studio, and then we're reporting out what changes we made to the people who were involved in the focus group. So again, having that feedback loop included to let people know in the community that we're not just there to ask you for something without giving something back to the community. And last, I'm going to talk about this community advisory board developed for Alzheimer's disease. And this is just a quote from one of my community advisory members. And I have to say, there's a lot of reasons why people choose to use advisory boards. And for me, I think it has been more on including them as research team members and helping to be a part of the strategic planning process, giving opportunities to them to be consultants on other grants. And for those researching it, some of them want to be part of the implementation of when we're running certain projects in the community, they want to be there. And so this quote here just highlights why champion and an advocate for Alzheimer's disease research and how she became all that it's so important to have these champions advocating in the community, because sometimes if you're the only one, you know, it buys you some credibility, but I think it's of showing the importance of their expertise and what they bring to the research program as well. So hopefully what I hope you have been able to see from what I've said so far is that when we do community engaged approaches and we really start to think about inclusion and culturally appropriate strategies, that it's not just one way to do it. There's a multi-methods approach that we need to start with and to even think about early on in our process. We need to understand our individual background, individual people that we are interested in being a part of our research or our program, their belief system. Again, building trust and a shared understanding of what matters most to them. Emphasis should be on improving healthcare and improving their outcomes, and not on blaming them for whatever position they find themselves in. And also exploring ways to integrate not only the person who is living with the disease, but again, looking at the family or other care partners or other care trusted members of their family that to be a part of those conversations. And then lastly, being present and visible in the community is essential. So as I said, we ask often to our CAB members, we ask to people in our research studies is what matters most to them today, and that can change. So that we constantly go back to our group just to make sure that we're doing what needs to happen in their trajectory. So cultural norms and values, understanding that structural barriers exist. We know that regardless of what disease, what condition, what program you're interested in, these next 3 points are just human values, right? People want to be valued no matter what your race. People want to be respected no matter what your gender or social identity, where you live. And people want honest communication. I don't think we talk enough about health literacy and how that influences the work that we do in community, and how that feedback loop needs to get back to people developing these programs, because I often think that that's a mismatch in terms of understanding how we move forward. So just to research and clinical implications at the end here is by saying, researchers, I believe, can be trained with an ability to discern how a host of issues defined clinically as symptoms or attitudes or diseases, how they also represent the downstream implications of a number of structural and policy decisions about healthcare, whether it's our food and delivery systems, our zoning laws, urban and rural infrastructure, or even how we discuss medicine and medicalization of things that we have in our community. I think that there are many educators and researchers and healthcare providers that now, if we start to have this approach, that we can really broaden and not only look at symptoms, but think about the social determinants of health and how those are also influencing how these biases or inequities really shape the way that we understand health and illness. And I'm just ending with my slide on acknowledgements of my research team. And this is just a portion of the folks that are working on the projects that I talked about today. And I say my community advisory board keeps me honest. So they have a lot to do with the work that I do, and of course, funding. So I think that is it. And I'm gonna stop share. Hold on one second.
Wow. Well, this is not it. This is just the beginning of more conversations. And Dr. Williams, thank you so much for sharing your perspective, insight, and just like a window into your many research projects. So I will tell you, I've got a couple of questions. No surprise on that. I know there's some students, I have some students who have been messaging me informally, and they want to come work with you. So you already have a fan club here at UMBC.
Awesome.
And
Please reach out. And I think my
right?
email is on the slide.
Yeah. So I have a question from, and I'm going to name her, I'm going to call it because she put it in public chat, Gretchen Tucker. Gretchen was at SGS presenting virtually on her dissertation research, and she's working with us on research on students as caregivers. But her question, so I'm going to read it so I can be specific. And they're all, everyone on the other side's mute, so I'm going to read this. So this is her dissertation, and she's looking at gender and racial disparities amongst the unmet needs of informal, non-spousal caregivers for community residing persons with AD and related dementias. Okay, so that's the laser focus is on that. She asks, do you have any suggestions on recruiting a diverse sample? And she's based here in the Baltimore region, of course, well connected, but here she's looking specifically on that, but what do you think?
Yeah, I think that yes, I have some suggestions, and I think the toolbox that the resource that I included there, I think that would also be a good resource to just have as part of your pocket of tools to use. But I think one thing people may not realize is that I was doing a presentation recently in a room of it was a small space, but maybe about 200 people. And the first question I asked is, how many people in the room either knew someone with Alzheimer's disease, was currently caring for someone with Alzheimer's disease, or had passed Alzheimer's disease? Every single hand went up in the room. So I don't think that it's hard to recruit people who are living with this condition or families that are experiencing this condition. It's really people are not talking about it, right? So we're not having conversations. So you may think that they don't exist or that you're not in the right spaces. But we have to think about how to reframe asking people. So one thing I don't do in recruiting people who have Alzheimer's disease is I always talk about memory. I always talk about memory loss, people interested in memory loss, and not using things like Alzheimer's disease or dementia, because
Mhm.
when you see those sometimes, what you're thinking, what individuals have said is that they like, well, I don't know, doctors never told me that, so I don't really know. So again, thinking about your inclusion criteria, are you only interested in a diagnosed or a non, or is it self-report? Like even that small distinction will open up doors to where you identify where participants are. Because if you need a specific and you think that's important for you to have a diagnosis, which for some research questions it might be, then going through a clinical sample might be the approach to opening sort of the scaffolding of participants. And so you might start in a clinic, identify some in that clinic who are partners or who know of advocates in their patient sample that then can open up doors to you recruiting people in the community. So I think there are multiple strategies. I always tell my students, you can't just do one. Like you're going to be doing this for a long time if you don't. You have to have multiple streams of talking to people, of putting flyers in strategic places that again often are where the people are. If you're looking for people living in the community, you need to go to the grocery stores, you need to go to the hair salon, you need to go to the barber shops. I think we don't give our men caregivers enough credit. Often they're not thought about in terms
Mhm.
of where they might reside. And I also do a fair amount of recruitment through faith communities. And so that's a variety of faith communities, but faith communities has been a source of great partnering for me in this space, because again, they see the decline of their members often and they don't know what to do. And so sometimes if you find a church or a faith community that has a health ministry or a paristry, like a nurse ministry or health and wellness, they are going to be your key advocates to identifying people that you're looking for. So those are just a few. I don't know how much more but those are some key areas I would start.
Yeah, I'm definitely seeing the need here for some, the continuing conversation. Sometimes it's just that I think of our students too, just like you say, you're working with yours, when you say to your students, you need to have more than one, right? And it's almost that permission to think
Mhm.
creatively. Another question that came in was about ethics. And
Mhm.
so, and I think having served on university IRB, institutional review board groups, being that senior group, and there isn't a category for people over
Mhm.
65 or those that have dementia. We obviously do look at the ability to give consent, right? But I do think about cases I've seen or reviewed or even research. There's always that issue about, well, you're working with people that have memory issues. How do
Mhm.
you navigate that? So maybe not from the IRB perspective, but it's a really
Mhm.
practical. And where has it been, where you feel it's been affirming, and where have you just maybe a case where you've just gone, wow, this is really challenging. And doing research, it is challenging. We'd like to hear more about that from your perspective.
Yeah, well, thank you first of all for that question, because I do wish we talked more about ethics. I think this is a critical piece across health conditions. So it's not just with Alzheimer's disease, but as people age, as those of us who are in gerontology know that this is a very sensitive topic. And at what point do you um, start to have these difficult conversations, as I say. And so for me in Alzheimer's disease, I've had a couple of ethical dilemmas that I'd like, that I feel like have taught, like I always feel like I'm learning, and I learn by talking to others and seeing how they've handled some of these situations.
Mhm.
But often I think that's why I do dyadic studies, is because I primarily think that even if a loved one has mild cognitive impairment, like they're just starting to see some, interferences with their daily life, but it's really, they're still able to function, they're still able to hold a job and do things. I always like to have a backup person that person chooses. Like that loved one will say, well, really it's my daughter, it's not, it's not my neighbor, it's not, I really want my daughter to be in the space with me, because then you start to allow, there's transparency about what's happening in the research process, or what's even happening in the clinical visit when you're in an office with a doctor. I always advocate for allowing a person in that's a partner with this dyad to really have a voice in that space as well, because there may be things that that person knows about the loved one that we as researchers just don't understand and don't see. And so for me, it's important to, even if it's not the unit of analysis, not the dyad, and it is the patient, still having the partner or dyad be a part of the, I think is always my go-to. The other ethical issue that I've had, and this may be unique to the geographical region that I'm in, is that the University of Virginia has one of the only sort of full neuropsych, full neurological assessment clinics in this part of this. For a long time, that we did not have enough neurologists to really do diagnostic testing for patients. And so a lot of my research was in rural communities, which are already under-resourced. And so because there's no, my push is for early detection. And so because we're still debating, I think the field about whether dementia screening is good enough for us, we're really starting to say, well, we got to get people in early no matter what. So I do dementia screening studies a lot, and many in rural communities. And I had to stop one of my studies because it took, for follow-up care, for them to actually get into the clinic to do a diagnostic test was a year. And I was like, here I am only giving a screening. I'm not even doing diagnostic testing, but you all can imagine in the audience, I'm sure, having people be told that they have some decline, just that in and of itself might send people into a, emotional, maybe upset, and my rural docs were like, wait a minute, I don't have anything, I can't do anything with this. What do we do with this once you give us this screening information? And so we actually not abruptly, but we closed the study until we could actually have enough, physicians in the clinic to get people in a timely fashion, because that was coming back on me as a researcher, because families would say, well, you told us all this information, but we don't have anything, we don't know what to do with it. And so that was early in one of my rural studies. And I just remember I was so afraid of messing up the relationships I had built with the primary care doctor in that community, and the families there, that I was like, well, they would probably trust me to come back if they knew that I did the right thing. So that's, and that's consistent. Like, we have really a shortage of gerontologists, we have a shortage of geriatricians, and neurologists, so it's a real issue that I think we have to continue to talk about. And that's why I really do hope we can, just educate more people who want to do aging work, who really want to go into these fields.
I know, because isn't this the most amazing field to be in? I mean, I don't understand why everyone doesn't get it, right? Like, I'm watching the clock, but we have one other, a couple of other questions, but one I just wanted to kind of a quick segue about the community engagement studio, because this is, I think of that as a way we really meld our community work and bring our researchers. I call it getting real. And it's something that we have tried on our end, working, and I think of the NSF projects I'm on, but with our computer scientists, our IS, our engineers. So it's really on the tech stuff and I always say, and this is a Southern phrase, bless their hearts, they want to solve people's problems. And sometimes I just like, but we need to bring the whole person into this discussion, right? It's not just like solve the problem at the end, So it's doing it right and having. I really want to hear more. I'm going to keep pestering you about the community engagement studios. Do you see it also as a way, and I'm kind of paraphrasing someone's question here, to actually be a vector's the wrong word, but a mechanism to kind of advance literacy, health literacy and communication about AD, about just what you said. You know, here it's one thing to identify, but it's another to bring it all full circle. So is that a possibility for the community engagement studios, or am I reasoning?
Yeah, I think it is. So when you first think about doing a community engagement studio, you go in with your question first, and sort of the whole process is they want you to come as early as possible, right? So like if you have that idea, you're like, I just want to see what this looks like. Like they want people from the very beginning to start having those questions. I love the idea of thinking about how to talk about literacy and communications around a particular study. So there's a clinical trial that's already started at the university, and they've reached out to me because they've heard that I've done these community engagement studios, and they were interested in learning, like, why have they not been able to engage certain populations? And so I was like, okay, so what are you going to do different if we're able to do this? Because that's the main thing with community engagement studios, is that they have a goal of whatever revisions that you make, like they anticipate revisions, right? They anticipate that you're going to make a change, and that change, like whatever that change is, has to be reported back out to the community. So I think that, how asking questions about, the literacy level, even though we advertise for a particular study, like they will review flyers if that's your goal. Like you can come back multiple times for a fee. You can come back multiple times to hold these about different components of your project. Now, I'm in a very beneficial position because I also have a community advisory board. So my community advisory board is really comprised of who live with the disease, people who are caregivers, people who work at organizations that support families with the disease. And so I would take flyers to my community advisory board, and they would blow them up. They'd be like, this is very gender neutral. This is not gender neutral. This is, and it's amazing. Like when you ask people their opinion and you value the types of information you get back, because we do pay our community advisory board members. They are, they're a part of our research team. So their voice is just as valued as when I bring something to the table. And I have to say that I have had my community advisory board currently, this is in the second year, and developing those relationships that first year is really primarily all we did. So there wasn't an ask, there wasn't a go get me people, there wasn't a, it was just, what do you think about Alzheimer's disease? How can we communicate? What is really important for you? Let's come up with a logic model. Oh, what is that? It's like, these are things. So I think, again, multiple methods of how to utilize these community engaged approaches is really key. But I think those type of community engagement studios could be beneficial for that.
Excellent. Well, this is a great segue to thanking you. And it is it's what a great Tuesday we've had, in a way to close out our Tuesday, to really kind of to reflect a moment on all our relationships. And I look at the people who've joined us today, and they really do span the spectrum, from University of Maryland, Baltimore, to our colleagues in the schools there, across all the colleges and units here at UMBC. And Dr. Williams, it's such a pleasure. I mean, what I really want is to have you here, and I'm like, so can we go out for dinner now? Like, I do. And so we all owe you a debt of gratitude for being here, and a coffee, something down the road. I really want to give a shout out to the Center for Social Science Scholarship, Dr. Felipe Filamo, who is here. He's been with us the whole time, and to Amy Barnes, who is I think she's the whiz behind the panel here that makes so much happen for so many of us at UMBC. And a shout out to Don Stout, who is with us. And for those of you who don't know, Don has joined the Erickson School of Aging Studies team. I think we just celebrated her month anniversary, and she's also part of our behind the scenes team. we were really fortunate in this particular lecture to have so many co-sponsors: the Hilltop Institute, the Delta Lambda chapter of Sigma Phi Omega, which is, I believe, one of the largest Sigma Phi Omega chapters, the Department of Sociology, Anthropology, and Public Health, the Office of Equity and Inclusion at UMBC, the UMB PhD Gerontology program, and the Center for Research on Aging. I think that's a pretty big list of co-sponsors, which really shows us how much Dr. Williams, your talk, your passion really sparked an interest across both our campuses. So I just want to thank everyone for joining us, and to remind you, the event has been recorded. It will be available through with closed captioning on the CS3's, I get the acronym right, YouTube channel with a link, and we will also post that link on the School of Aging Studies website. So thank you, everyone. It's been such a pleasure, and happy Tuesday and Careers in Aging Week. Thank you, everyone.
Thanks again for having me, Dana.